So patella fractures after total knee. Let's go back one here. So I am substituting for J.B. Brown. These are his slides. So patella fractures are very different from traumatic patellar fractures, and really important to remember that. Because I see a lot of patients coming in with patella issues into the clinic, and they've been treated by maybe a traumatologist, and it's been done in a very trauma-esque way, and it's failed. So you have to remember the vascularity, the blood supply is not what it was normally. There could be possibly some osteonecrosis going along with this. There's reduced bone stock and older patients with comorbidities. So the patellar fracture after total knee arthroplasty, the prevalence is about 0.6%. It happens more in men than in women. This paper by Dr. Ortiguera and Berry from 2002 showed that there were a high rate of complications and reoperations when treated surgically. The type 1 is the implant is intact as well as the extensor mechanism. Type 2 is the implant is intact as well as the extensor mechanism is disrupted. And then type 3s are when the implant's loose. And A's are good bone stock and B are poor bone stock. Typically, your 2s and 3s are going to require operative intervention, and we'll go into that further. So type 1, implant and extensor mechanisms intact is the most common. It's likely underreported, maybe entirely asymptomatics with those patients, and these tend to be early on, within 2 or 3 years of surgery. We immobilize these for 6 weeks in extension typically. These are ones that you probably don't want to operate on. The surgeries are rare. Here you can see somebody that's got a fracture, and with time, that goes on to healing. Here's another one, an unresurfaced patella with a fracture, and that goes on to heal as well. So type 2, implants intact and extensor mechanism is disrupted. The lack of the extensor function drives the surgical intervention. So your options for treatment there are internal fixation of your displaced fragments. This is usually pretty unsuccessful. So trying to do wires in this situation usually falls apart, and I've never done that treatment. Taking out the smaller fragment of bone and advancement and repair of the extensor tendon to bone is a pretty typical treatment in these situations where you have a smaller piece, you can advance that and use Krakow sutures and bring that all together. The patellectomy with extensor mechanism reconstruction, I don't really like taking out the patella and doing a reconstruction, but if you need to do it, you can. So here's an acute injury with good tissue and bone stock. You can see that sleeve that's come off, and then it's been removed and advanced, and you've got a good reconstruction. It's important to remember you need to leave these patients out straight for 6 to 8 weeks so they can heal. There's been a number of techniques described as ways to fix this, either through transosseous tunnels with suture. That would be more what I've done in the past. Suture anchors are an option, as well as the tension band technique. I worry about the wires breaking with the tension band technique, and that would be reserved if you had just really excellent bone or maybe an unresurfaced patella. Postoperative management, strict immobilization for 6 weeks. Again, in most of the papers, despite all this, there's a high rate of complications and poor clinical outcomes, so you need to remember that in these situations. So when you have the type 2s, again, implant intact, extensor mechanism disruption, but there's not a lot of great bone. We can start talking about the patellectomy, and this would be where you've got very little bone, it's very fractured, the bone quality is very poor. Maybe somebody else has tried to repair it in the past. I think in these situations, it's probably better to get the bone out so that you can now focus on a better extensor mechanism repair. In your type 3s where the implant is loose, non-operative if your symptoms are minimal. So sometimes we have somebody sent to us, an elderly patient, they've got a patellar fracture, we can see that the implant is loose, but they have no symptoms. That's the last thing you want to do is go ahead and operate on those patients and cause a problem, an infection. But if you do need to operate, if you've got good bone stock, you can revise a patellar component versus doing a partial removal of bone and repair with patelloplasty, or you could remove the implant and just leave it as more of an unresurfaced patella. If the bone stock is poor, go ahead and remove the implant, and you're back to doing either a patellectomy with an extensor mechanism reconstruction. And this is typically where I'm going to be using the Marlex type mesh reconstructions. Typically, if I'm not really happy with the quality of the tissue, in most of these situations I'd be doing an extensor mechanism reconstruction, and one of the other speakers is speaking about that. So really, prevention's the best medicine. Think about patient-related, implant-related, and your technical things that might lead to patella fractures. Usually my larger obese males that are more manual laborers are the ones I really think about not resurfacing. I don't ever go any thinner really than 14 millimeters with thickness if I can. Avoid lateral releases for osteonecrosis. And use care with uncemented fixation. Make sure that they've got adequate bone stock to be able to get an uncemented patella. So non-operative treatment where feasible. Surgery is reserved for extensor mechanisms disruptions or a symptomatic loose patellar component. Operative treatment frequently associated with complications and poor patient satisfaction. Thank you very much.